the next speaker, I'm going to invite Dr. Ashraf Amir. Dr. Ashraf Amir is a consultant family medicine at the International Medical Center. Please, Dr. Ashraf, he's going to talk to you about hypertension and smoking.
طيب الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank you for attending my session, and I would like to thank the organizing committee for inviting me today in this very prestigious conference to talk about a very important topic that we all encounter in our daily practice. And let me start by a statement to say that all of us, we agree that most of the chronic disease that we have in our population in Saudi Arabia, like hypertension, diabetes, ischemic heart disease, cardiovascular disease, are always connected strongly to a modifiable risk factors like weight, obesity, improper diet, exercise, as well as smoking. And in fact, smoking is the most important modifiable risk factor for cardiovascular disease, and smoking is always associated with a high risk of cardiovascular mortality and morbidity. So within this coming 20 minutes, I will try to limit myself to the short time given, but I will try to bring the associations and to prove to you through certain evidence that there is an association between hypertension and smoking, cigarette smoking, or even tobacco smoking. So my objective in this presentation, just only two objectives. One is to walk you through certain evidence to make sure that there is a strong association between tobacco smoking and hypertension. And then the most important part of my presentation will be at the end, which will be highlighting and emphasizing our roles as physicians to tackle this kind of problem among our patients, regardless of our specialty. So we are going to talk a little bit today about tobacco smoking and hypertension. So you will see that I'm trying to separate hypertension alone and tobacco smoking alone to start with, and then I will combine them together. So as you know, according to the latest evidence about the prevalence of hypertension in our society, which has been published in the Saudi Hypertension Guidelines in 2018, of course, there is many trials, cross-sectional trials, but the one which is more appropriate is the Saudi Health Interview Survey, which was published in 2013, and it demonstrated that the prevalence of hypertension is 15.2. But the question here, are we doing good in managing our patients with hypertension? Definitely no. Why? Because we have only 5.4% of our hypertensive patients, they have been treated to the target. Again, we have almost done 78% of our patients who are hypertensive, yet not yet diagnosed. So there is a huge problem, and of course we have multiple factors contributing to this. One is patient factor, one is physician factors. We have a clinical inertia to manage this kind of cases, and then ultimately the last one is the healthcare system factors. So let's go through the prevalence of smoking in our society. According to the Tobacco Atlas, which was published a couple of months ago this year, they have distributed the demographic or the geographical distributions of the smoker across the globe. So what is the share of these populations of smokers in our region in the Middle East, particularly in Saudi Arabia? They're about 20 to 40%. But according to the statistics which has been highlighted, we have 20 to 30% of our Saudi populations, they are smokers. And unfortunately, we have a new population group has been added on top of what we have, those who are teenagers, ladies who are pregnant, and again, the healthcare providers. So unfortunately, there is about 40% and more in Turkey of the healthcare providers, they are smokers, and they are not presenting themselves very professionally when they are presenting themselves as a vehicle of healers to treat certain disease. So we have to maintain the role of model to ensure that we can deliver the message clearly and with a good acceptance from the other end, who is the patient. I thought just to highlight the important part about the component of the cigarettes. It's not all about nicotine, which causes the addictions. We have more than 4,000 different chemicals. We have more than 250 toxic substances and a lot of carcinogenics. And this promotes the smokers to have multiple comorbidities and mortalities because of these substances. But what the drugs, the tobacco industries companies, what they have done in the previous years, in the past 1 or 2 decades, they have added certain substances to enhance the adherence of the smoker to the cigarette. So they have added bronchodilators in order to bronchodilate, the bronchus to inhale or to accommodate a larger capacity of the smoke. And then they have increased the nicotine to make the smoker more addicted. They have added certain substances like the menthol, which cause the soothing of the throat and make the smoker more pleasant and relieve the irritations. Many substances has been added, and the ultimate goal was to keep our patients and our people more addictive to cigarettes. So to know that there is no single organ, there is no single system in the human body is deprived from the bad effect of cigarettes. So there is a big list of chronic disease. The most important one is the cardiovascular disease and the COPD. We have a big list of cancers, just name it, from the lung to the stomach to the bladder and so forth. But if you want to summarize what is the bad effect of the smoking on the health of the individual, so it's a cardiovascular disease, which will be followed by the COPDs and certain cancer. And it is usually duration related. So those who smoke for a longer period of time, they have more complicated, and even the durations and the dose. The more they smoke, the duration more, definitely they will have more complications. So my question to you, how many current smokers will eventually be killed by their tobacco use? Is it 1 in 20, 1 in 10, 1 in 2? Anyone? Anyone? Thank you very much. So it is 1 in 2. So they said the only legal product available to the customer that caused the death of about 50% of its regular users is a cigarette smoking. So it kills 50%. 1 of each 2 are killed because of this. And this is one of the studies which has been highlighted, that there is a span of the survival of 10 years between the smoker and non-smoker in a survey which has been extended for many years. And there was no difference at the age of 40 between the 2 groups, but when they advance in age, at the age of 60 or 70, there was a span of 10 years survival in favor of non-smoker. So here the question and the main objective of my presentation: can tobacco smoke lead to hypertension? I will walk you through certain studies. So this is one of the studies to show the effect of smoking on the blood pressure in normotensive men. And this was conducted in Manipal University in Mangalore in India. It involved more than 2,000 workers in a factory in India. And after 6 months, the same subjects were examined, and the result was there was a rise in the blood pressure, systolic blood pressure in the smoker compared to non-smoker. Another study, which was a prospective study of cigarette smoking and the risk of incidence hypertension in women, and this was in Boston. So it's extended to almost 10 years with populations of women of more than 28,000. And they have no hypertension, no cardiovascular disease, and no cancer at all to start with. But what happens? And this is the baseline, in fact. You can see that among the population whom have been studied in this trial, 50% were non-smoker, 36% they were ex-smoker, and those who smoke less than 14 cigarettes per day, there were only 5, and those who smoke more than 15 cigarettes per day, there were 8%. So let's see what was the result after 8 years. So there were almost 30% of those patients or those people or women who were involved in this study, and they were not normotensive. They become, after 9 years, about 30% of them, they were hypertensive. And the conclusion was, in a large cohort of men, cigarette smoking was associated with an increased risk of developing hypertension, with an effect that was strongly among women, who smokes more than 15 cigarettes per day. So the durations and even the dose was contributing to the high prevalence of hypertension. Of course, the cardiovascular mortality for the current smoker usually rises between 1.5 to 3-folds. And we can see here in this slide, the death from all vascular disease is about 3-folds. Death from ischemic heart disease was almost 3.5-folds, and death from stroke was about 3.2-folds, and death from other vascular disease was in male more than 3-folds. So the conclusion was smoking increased the individual risk of death for all vascular disease by about 1.5 to 3-folds. So if we just identify smoking, hypertension, and hyperlipidemia as a different entity, but they are having a contribution to the cardiovascular risk and cardiovascular mortality and morbidity. So as we know, the smoking will increase the risk for cardiovascular disease by 1.5, hypertension by 3-folds, hyperlipidemia by 4. But if you just combine smoking and hypertension, so the folds will be up to 4.5 risk of cardiovascular disease. And if you combine smoking with dyslipidemia, the risk will be as high as 6. But if you just combine it all together, and many of our patients, they have this kind of combinations, so definitely the risk will be very devastating that the patient will be a victim of cardiovascular mortality and morbidity. So let's go through the mechanism and understand a little bit about the pathophysiology of this tobacco smoking and how it affects the cardiovascular functions. So the two important elements that we would like to focus is the nicotine and the carbon monoxide. So here, if you just can have a look on this, so the smoking, if we just take the nicotine out of the smoking, so there will be a vascular dysfunction. So it increases it's not clear. I will have a look at it here. Okay. Right. Anyhow, so it causes a vascular dysfunctions, and it affects the lipid metabolism, and it develops atherosclerosis, and it causes a lot of and it increases the sympathetic activities and ultimately increase the blood pressure. And all these factors, when they are contributed together, they affect they cause the dysfunctions of the cardiovascular system because of the endothelial dysfunction, and ultimately they result in myocardial ischemia and all the complications of the cardiovascular functions. So to conclude, because the slide wasn't very clear, I apologize for this, but to conclude, what is the effect which is mediated by the nicotine on the cardiovascular system? So definitely there will be a sympathetic nervous system stimulations, and this will result in hypertension, increase in the catecholamines release, and this ultimately causes the hypertension, and increase the heart rate, endothelial dysfunction. This is the most important element that causes the damage by the nicotine in the cardiovascular system, and then ultimately there will be a development of atherosclerosis. So if we would like to have a look on the carbon monoxide decreases the availability of the oxygen, because the carbon monoxide has more affinity to the hemoglobin rather than the oxygen. So there will be decrease in the myocardial oxygen uptake, and ultimately there will be a myocardial infarctions, and ultimately will be a cardiovascular dysfunctions. And of course here, if we just look into the cardiovascular risk reduction by the quitting, so this is the benefits which we are going to get because of the quitting. So it depends on the dose, how many cigarettes the patient smokes. It depends on the durations, how many years. And it depends on age. If the patient is elderly, so definitely the comorbidities will be much more highlighted. And even the other comorbidities like hypertension, like cardiovascular disease, or even COPD. So the quitting before the age of 4 years reduced the risk of tobacco-attributed death by 90%, which is really huge. And nearly half of the excess of cardiovascular risk is eliminated by 2 years of quitting. As you can see here in the graph, within 2 to 4 years, about half of the risk has been deducted. So smokers with congestive heart failure if they have smoking, if they get the smoking cessation or decrease the mortality by 30% in the first year of cessation, and smokers who quit after myocardial infarctions, they have 36% reductions in the cardiovascular mortality over 2 years compared with the non-smokers, with the continuing smokers. And quitting after CABG or PCI improved the survival and reduced the risk of additional procedures and the risk of the death compared with the individuals. And in fact, there is many trials to support this kind of statements. So this was the first part. This is the most important part of my presentation. So what is next? What is our role? What is our responsibility towards our patients? So definitely, we have to know that now they consider tobacco smoking or cigarette smoking like any other disease, like any other chronic disease. Why? Because it's a long-term duration. Most of the smokers, they smoke for decades. And moreover, it has a period of relapses and remissions. So the patient goes into relapse, try to quit, and then he goes back again. And he has acute bronchitis back and forth. And it requires an ongoing rather than acute. So let's understand what is the cycle of nicotine dependence. So as you see, when the smoker smokes cigarettes, there will be a release of nicotine. And nicotine will be attached to the nicotine receptors, and there will be a chemical reactions for which there will be a release of certain dopamine. And this dopamine will give the pleasure and the happiness and the focus and the concentration of the patient who smokes. And then, because of the lack of the nicotine, there will be a drop of dopamine, and the patient will be subjected to the withdrawal symptoms of smoking. So the tolerance decrease sensitivity by the time those who are smokes, 1 cigarette or 1 pack, definitely after 10 years, they need 1.5 pack because the affinity of those receptors will get reduced by time. But again, the smokers will try to accommodate this by inhaling more and keeping the smokes within his lungs for a longer period of time in order to saturate those receptors in the brain. So we have to remember that there is certain withdrawal symptoms, which is usually the very devastating, experience of most of the smokers, and it's considered to be one of the cause for failure of treatment if you don't address it. So those patients, if they quit smoking without any help, definitely they will have irritability, anxiety, restlessness, they have increased or decreased appetite, they have insomnia, and they will become very agitated. So this is very important. Here, I would like to share with you one of the initiatives that we have done it in my hospital, the International Medical Center. So we thought that we have to take it as a corporate social responsibility. It should be not a missed opportunity for any patients who come into the hospital and he's a smoker and seeking some other help from any healthcare providers. So we have modified our health system to identify. So, do you smoke? Yes, no, or ex-smoker? This is a question which has been implemented in the health system, and it will be counted as the 5th or the 6th vital signs. So the nurse will take the vital sign, and the 6th question will be asked, do you smoke? Yes, no, or ex-smoker? If he's a smoker, the system will be alert with this, and the patient will be alert to all the doctors across the board, regardless what is his specialty, even if he's orthopedic or dermatologist or whatever. So he will be flagged with this. So he has no choice but to provide the patient with a 3 seconds smoking cessation brief advice. And we have trained all our doctors with this. So this will be an opportunity to convert the patient from the pre-contemplation state to the contemplation state, and then he will be very appropriately managed. And then the patient will have, and the doctor will have to refer the patient to the smoking cessation, or he will have to say that the patient is refused. So what happens? The patient will be counted again and again, and the other visit will be repeated till the patients get the concept that he has to go for the smoking cessation. And we capture a lot of patients by this initiative, and it's become very rewarding for all of us to have a healthy community within our organization. So it's again very important to identify whether your smoker is addictive or not addictive, and what type of addictions. So this is a brief Karl Fagerstrom is a French scientist who developed this question. How soon after waking do you smoke your first cigarette? Less than 5 minutes, this is 3 points. 5 to 30 minutes, this is 2 points. 31 to 60 minutes, this is 1 point. The other question, which has been validated and with the high sensitivity and specificity, is How many cigarettes do you smoke each day? More than 30 cigarettes, 3 points, 21 to 30 cigarettes, 2 points, and 11 to 20 cigarettes, 1 point. And then comes the scoring keys. So if you have a patient who scored 5 to 6 points, he is a heavy nicotine dependence. And what does it mean? That means that you have to use a combination of medications, you have to use the medication for a longer period of time, and you have to make sure that the patient get a multidisciplinary team approach, psychologist, educator, and everybody should share with you this kind of patient, because he's a very difficult patient to manage and a very fragile patient to get into relapses. But if the patient has 3 to 4 points, this is moderate, and if the patient has 2 points, this is light nicotine dependence, and they can go cold turkey. Cold turkey means by their will they can manage without any medications. So, I have time? Okay. So there is 5 A's and 5 R's. So those you patients who have been convinced to be a quitter and they are getting to you to quit smoking, ask the 5. Ask about the smoking. How many cigarettes and how long the duration. Advise every smoking to stop smoking. And they have identified the question. If you say to your patient, if you quit smoking, or smoking quitting is the best thing that you can do for your health, this is a very validated question, and this will convert the patient to an active patient to perceive what you have said. Assess the readiness of the quit every visit, and to see if the patient is ready, so you can start. If not ready, you can ask him to come again. Assist the smoker to stop smoking and arrange for follow-up and monitor. But if the patient is reluctant and he's resistant, so go for the 4, 5 R's. Relevance, tailor your advice and discussion to each patient. Now we are in the era of medicine where we talk one size is not fit for all. We should customize our management plan based on the patient profile. Each patient with you, he should be tailored according to his need, the medical, the psychological, the medical, the social, the psychological needs has to be addressed. So then outline the risk of the continuous smoking, tell him about the bad consequences, and reward. Outline the benefits of the quitting smoking, and then the roadblock, identify the barriers. Each one of the smokers, they have certain barriers, and you have to highlight it and you have to address it. Otherwise, you will have misunderstanding why the patient is not getting into the quitting stage. Repeat it. Just keep on repeating these 5 A's every encounter with patient to convert the patient into a patient who really decisive. So let's go quickly about the pharmacotherapies. In fact, we have many medications. In 1970, they have introduced the behavior modifications, which works very well, but actually it wasn't enough. But later on in 1980s, we started having the nicotine replacement therapy, where we have now the gums, we have the patches, we have the lysogens, we have the sprays, and we have a lot of devices that deliver nicotines. Okay? So what is the benefits of this nicotine? We are giving the patient the same nicotine in the cigarette without the toxic substances. And we go into certain, the one which is more available here is a nicotine patch. We have 21 milligrams, we have 14, and we have 7 milligrams. So if the patient is severely addicted, so you go with a higher dose for 21 milligrams for 2 or 3 weeks, and then after that you go for 14 for another 2 or 3 weeks, and then 7 milligrams for another 2 or 3 weeks. And always remember, please, medications alone never work. So the combinations of behavior modifications, psychosocial support, and then come the medications. So 3 elements: behavior modification, psychosocial support, and medications. It will work.
Will you conclude, please?
Yes. So the second medication is bupropion. This is an antidepressant. It works very well. And usually in difficult cases, we combine the nicotine replacement therapy with bupropion and give us a very good result. But the most advanced one, which has been released in the market in 2009 or 2006 in the States, 2009 in Saudi Arabia, is the Champix, which works in the brain. It blocks the nicotinic receptors and releases certain amount of dopamine, so it prevents. Even if the patient smokes during the therapy of Champix, he doesn't have the same flavor which he got to use with a regular cigarette. So these are the medications. So there is a side effect. Please go read about it and look into it. And if you need any help, I'll be very pleased to provide you with all the details because of the short of time. So in 2011, I've been privileged to be one of the co-authors for the smoking cessation in the Middle East and Africa, and we have published a very nice recommendations. So if you would like to go through it, you will have all the details, how to manage the regular patient, the difficult patients, and all kind of dilemmas and frequently asked questions in this. So to conclude, ladies and gentlemen, cigarette smoking is a powerful modifiable risk, the cardiovascular risk factors, so it's a modifiable. Still, we can do something good for our patients with a minimal efforts and a cost-effective measures. And this smoking cigarettes contribute significantly to cardiovascular mortality and morbidity and impact all the phases of atherosclerosis from endothelial dysfunction to the acute clinical event. So those patients, they get into endothelial dysfunctions and then they will be a victim for acute events from time to time and exert an hypertensive effect mainly through the stimulations of the sympathetic nervous system. And this is the conclusion which I would like to highlight it to you. And now we have the clear association by evidence that there is a very strong association between the smoking and hypertension. The role of us as a provider is to give a smoking cessation brief advice, which will take only 3 seconds. Okay, 30 seconds, but it has a very good impact of our patients, and we have to refer patient to the smoking cessation clinic for psychosocial support, for behavior modifications, and pharmacological therapy. With this, I would like to thank you for your listening, and I wish you a very successful management of our hypertensive patients who are a smoker. Thank you very much.